Thanks everybody for joining us this morning for the echo rounds. As mentioned, my name is Samir. I'm one of the cardiology residents here at St. Mike's, and we'll be talking about echocardiography in the trauma patient. So the objectives for this presentation are to understand the utility and limitations of transthoracic and transesophageal echo for the rapid assessment of the trauma patient, to develop a systematic cardiac-focused approach to assessing a trauma patient, to recognize key echo findings of important trauma presentations, and to understand the use of echo for hemodynamic assessment and resuscitation. I don't have any conflicts of interest, but I should mention that my training is primarily in internal medicine and cardiology, not in trauma, so I speak mostly from that particular lens of this topic. If there's anybody in the audience who has more experience in trauma medicine, I'd love to hear your perspectives later on as well. So during this presentation, I'll talk a little bit about the why and the when of echo use in trauma situations. We'll go over a clinical approach to assessing the trauma patient and various important cardiac presentations of people coming in with trauma. I'll go over echo-guided resuscitation, and then we'll finish just with a brief mention about the future of echo in trauma. So first, why is this a relevant topic, and why is echo used in trauma situations? Well, echo is it's a very accessible diagnostic tool that's becoming increasingly accessible with the use of smaller devices that can attach to phones and other devices. And it can be used very quickly on an unstable patient. It can be used to rapidly investigate the cause of shock and modify management at the bedside. And pretty much any clinician can be trained in undertaking a basic assessment with echo. We also, in cardiology, and our sonographers also teach many other specialists and future subspecialists outside of cardiology. So it's important to get a sense of some other applications that our colleagues might be using echo and ultrasonography for in the future. And also the principles of echo for trauma can be expanded to a lot of other situations that we commonly deal with, such as the management of patients in the peri-procedural or peri-operative setting, or people coming into the CCU or wards with undifferentiated shock. We use echo at various different parts during the care of a patient with trauma. It's used even in the primary assessment, in the trauma bay, and in the emergency department. We, as cardiology and internal medicine physicians, are less commonly involved at this point, but on occasion we do get called to the trauma bay. Our anesthesiology colleagues and emergency colleagues, however, use echo very frequently in the trauma bay to assess patients. We sometimes use echo perioperatively, either in the OR or after the OR, to assess patients. Or most commonly, we in cardiology will see patients after the initial resuscitation, whether that be a medical resuscitation or after they've undergone some surgical procedure to fix other traumatic problems. And then very often we'll also see patients to deal with some of the late complications of traumas. This diagram just shows one of the commonly described concepts of the cardiac box, which is roughly the area bounded by the nipples on either side, the clavicle, and the xiphoid process, with the idea being that penetrating injuries in this area are more likely to cause cardiac injury. I think some people in the trauma community think this is a less useful concept nowadays, but it seems to be more true of knife wounds rather than gunshots or other projectiles, which can have more unpredictable courses. Now, cardiology isn't typically part of the trauma team, and so it's good just to understand our role in those situations. Trauma, like code blues and other acute medical situations, can have lots of competing priorities from different people in the room. And the information that we're asked to provide can help to guide the management and prioritization of the many other tasks that need to go on to take care of the patient who's undergone polytrauma. For example, the information we provide can help to determine if there's an urgent cardiovascular or surgical issue, or understand the hemodynamics of the patient in preparation for an operation for another organ system. Ultimately, it's important to recognize that trauma is a team activity and we don't work in isolation, and we need to work in concert with all the other teams that are present. There's many reasons why we would do echo in a trauma patient. I think it should always be considered if somebody is hypotensive, especially if they're not responding to initial resuscitative efforts. In patients coming in with cardiac arrest, one of the key factors in them surviving that arrest and surviving to discharge is early identification of the cause of their arrest, especially if it's something that can be reversed. In patients who are hemodynamically unstable but haven't yet arrested, it's very useful for looking into the cause of their undifferentiated shock, which we'll talk about more later on in the presentation. And transesophageal echo is also a very useful modality for cardiac surgery and for non-cardiac surgery. It can be used in the intraoperative setting for hemodynamic and structural assessments. It can be used in patients who have a suspected or known thoracic aortic dissection or other cardiovascular pathology. And it can also be used intraoperatively and postoperatively to assess the quality and positioning of aortic repairs. It can be used in patients who are at high risk for myocardial ischemia, again for hemodynamic monitoring, and in patients with unexplained hypotension or persistent hypoxia, or in other patients who have not clearly sustained a cardiac injury, but have had major injuries to their abdominal area or to their thorax. For transthoracic echo, there's not really any absolute contraindications. It can be technically challenging depending on the nature of the trauma, but there are some important contraindications to transesophageal echo to consider. A lot of them are medical or things that might have existed prior to the trauma, largely related to issues with the esophagus and the gastrointestinal tract. So things like esophageal stricture, if somebody is known to have undergone a recent esophageal surgery or gastric bypass, if they're known to have an esophageal or gastric tumor, or if they're known to have some other disease such as a Mallory-Weiss tear or scleroderma that's affected the esophagus. And then there's a number of trauma-related factors to consider before doing a transesophageal echo, such as if they've had a basal skull fracture, if they have an unstable C-spine injury, the presence of a C-spine collar, if there is not a confirmed C-spine injury, is more of a relative contraindication, but should certainly still be done with caution. If a patient has an active upper GI bleed, an unprotected airway, if they're known to also have an esophageal injury or a pharyngeal trauma, these might all be reasons to give pause about doing a transesophageal echo. So there's clearly some limitations and challenges to performing an echo, especially a transthoracic echo in a patient with trauma. Image quality can be quite challenging because of the presence of subcutaneous emphysema, bandages, pneumothoraces, or other instruments in the field that you're trying to access. The team dynamics, as I mentioned, can be challenging, and it can be a very busy environment with many other people assessing the patient and triaging for their particular organ system. Time can be very much of the essence, and there might be lots of other urgent procedures pending, and the cardiac findings may greatly alter the triaging process for these other procedures. And the patient may be a lot more unstable than other patients who we're commonly working with. So when I'm thinking about the trauma patient that I've been called to assess, as I'm going down to the emergency department, I'm always asking myself a few important questions. Number one, I'm trying to think about if they are stable or unstable, as this will affect how quickly I need to get to the patient and do the echo. But also whether I have time to gather collateral clinical information, or if I can get other tests such as CT scans to corroborate my findings. I'm thinking about the mechanism of injury and whether it's blunt or penetrating injury, how likely it is that I think there will actually be a cardiac injury, and what type of cardiac injury I might be looking for. And I'm thinking about other co-injuries, things that might make it difficult to assess the heart, or that may need to be managed even more urgently than the heart, assuming that there's no catastrophic cardiac complication. So like many differentials in cardiology, I often take an anatomical approach to thinking about differential diagnosis for the heart, and thinking about the different components in the heart that might malfunction to impair its pumping function. So I think about the pericardium, the myocardium, the coronaries, the valves, and the electrical systems, although I won't go into the electrical system very much today. So this is our first demonstration echo. I don't know if I have any of the cardiology residents on the line who want to just briefly say what they see. I know it's a subtle finding. If no one speaks in about 10 seconds, I'll just talk myself.
Can you hear me?
I can hear you, yes.
Perfect.
but you'll be quiet.
I don't know, the microphone's not working that well. So parasternal long view, you can see quite a large pericardial effusion in addition to a pleural effusion.
Yeah, great. LV function looks grossly normal. And here, anything else?
You can see, you can see RV and RA collapse. So it looks like signs concerning for tamponade, in addition to the heart swinging within the pericardium, in the pericardial fluid.
Yeah, beautiful. So exactly. So on the left, there's an apical 4-chamber shot with a large pericardial effusion. It measured out to about 2.5 to 3 centimeters at its largest. As mentioned, looks like there is probably some chamber collapse of the right atrium and the right ventricle. And you can certainly see a bit of a swinging motion. So all this is concerning for the development of tamponade. And you can also see that the patient is a little bit tachycardic. Just as a general disclaimer, of course, tamponade is a clinical diagnosis. So just a friendly reminder to break out your sphygmomanometers and make sure you're measuring the pulsus paradoxus and not just going by echo. But of course, echo is a very useful adjunctive tool to diagnosing echo or looking for features that may, for diagnosing tamponade or for looking for features that may develop into tamponade. So there's multiple findings that we look for on echo. The pericardial effusion is an echo-free space in the pericardium that is anterior to the descending aorta, and versus a pleural effusion, which is posterior to the descending aorta. So as mentioned, the previous echo had both pericardial and pleural effusions. The pericardium may have echo-dense components such as blood or hematoma or fibrin, or it could even have air, which is called a pneumopericardium, from sources external to the body or from the GI tract or respiratory tract. And pericardial effusions can occur because of blunt or penetrating trauma, can occur because of injury to the myocardium and free wall rupture, or it can be because of the development of pericarditis, coronary injury, or an aortic dissection that's extended into the pericardium. When we talk about the size of a pericardial effusion, we have these general categories. There's also trivial, which is essentially an effusion that disappears at the end of diastole. And then we categorize them into small, moderate, and large based on whether they're less than 1 centimeter, 1 to 2 centimeters, or greater than 2 centimeters. A moderate or larger effusion is generally circumferential, although in trauma and in perioperative situations, it can sometimes be more focal. And the size of the effusion sort of roughly corresponds to the amount of fluid that we expect there to be in the pericardial space. And just to mention that when we're actually measuring the pericardial effusions, we do so at the end of diastole when the effusion looks its smallest. So I'll just briefly touch on some of the physiology basics behind tamponade because it's relevant to the echo findings that we see. So in normal inspiration, we generate a negative intrathoracic pressure, and in doing so, we increase venous return to the right ventricle. This causes the right ventricular volume to increase, and for the left side, it also acts to assist left ventricular filling by essentially using the chest wall to help open up the left ventricle and improving that transmural pressure gradient. When we develop a pericardial effusion, it increases intrapericardial pressure, and it also somewhat shields the heart from the negative pressure generated by the chest wall on inspiration. So with tamponade, the heart now exists in a fixed or relatively fixed cardiac space. And when we take a breath in and inspire, as we increase the right ventricular filling, this occurs in the confined space, and it impairs left ventricular filling by causing deviation of the septum towards the left ventricle. Because it also acts to shield the heart a little bit from the intrathoracic pressure changes, there is less of a pulling effect on the left ventricle when we take a breath in, and so it is less able to assist the left ventricular filling, which in combination with the changes in the right ventricle, impair cardiac output, impair stroke volume, and decrease our blood pressure, causing the classic finding of the pulsus paradoxus. There's many sonographic features of tamponade, some of which were described in that last echo. So certainly a pericardial effusion has to be present. It can sometimes be difficult to differentiate from pericardial fat or a pleural effusion, depending on how good the images are. We often see chamber collapse, most commonly in the right atrium, which is the most sensitive feature in terms of chamber collapse. And we sometimes see right ventricular collapse in diastole, which is relatively insensitive, but a more specific finding of tamponade. On occasion, we'll also see left atrial or left ventricular collapse, but they're very rare, but quite specific for tamponade if they occur. IVC plethora, or a dilated non-collapsible IVC during inspiration, is a helpful finding, again, because it's quite sensitive. It's only helpful, or it's more helpful in patients who are spontaneously breathing rather than patients who are mechanically ventilated. We can see respirophasic variation in septal motion because of some of those physiologic changes I mentioned. And we can see respiratory variation in valve inflow velocities, which are defined as being significant in the variation in inflow velocity at the mitral valve is about 30% or more, and in the tricuspid valve, 60% or more. And the velocity change is calculated as described in the formula. And then finally, we can also see changes in our pulmonary vein and hepatic vein flows. So in the pulmonary vein, we can see that the diastolic forward flow that we expect to occur into the left atrium is reduced with inspiration because of those physiologic changes I mentioned, which impair filling of the left ventricle. And in the hepatic vein, during diastole, when you would expect there to be good forward flow towards the IVC, we can see that this forward flow is decreased or reversed with expiration. So these are some of these findings in pictures. So IVC plethora is seen here with a dilated, probably about 2.5 centimeter IVC with less than 50% respiratory variation. Here we see an M mode through the parasternal short axis view with the classic respirophasic changes in the size of the right ventricle, left ventricle, and septal shift. So on inspiration, which is when that green line is peaking, we see that the RV preload increases, RV afterload decreases, and this causes the septum to deviate from the right towards the left ventricle. We see the left ventricular size decrease and the right ventricular size increase. On expiration, we see the opposite, where there's decreased right ventricular filling, RV size becomes smaller, the septum deviates back to the right, and the left ventricle size increases. And then this is a helpful way to look for right ventricular collapse in diastole. If you actually take an M mode through the subxiphoid view, which is the easiest view to appreciate this, you can see that if you time it out and look at the wall of the right ventricle during diastole, it bows in right here, which is not expected outside of the context of tamponade. Tamponade in trauma patients can be a little bit different in its presentation from other causes of tamponade that we often encounter. So tamponade can be caused by a relatively small effusion because the rapid increase in pericardial fluid, such as from trauma or periprocedural issues or perioperative issues, quickly exceeds the amount of pericardial reserve, causing a very steep increase in intrapericardial pressure. This is compared to other causes of pericardial fluid accumulation, such as dialysis or renal failure, malignancy, tuberculosis, where the pericardium has a lot more time to stretch and is able to accommodate much higher volumes before it ultimately causes hemodynamic compromise. Many trauma patients are also on positive pressure ventilation because they're intubated. And so this can increase pulmonary pressures and RV afterload. And we may not see some of the typical echocardiographic findings, such as right atrial or right ventricular chamber collapse. So they have a decreased sensitivity. We also see that some of the chamber size and inflow velocity variation patterns that are classic in tamponade may be reversed because when patients are inspiring, they're undergoing positive pressure ventilation rather than and generating a positive intrathoracic pressure rather than a negative intrathoracic pressure when somebody is spontaneously breathing. In trauma, as mentioned, the pericardial effusion may also be focal and less circumferential, as we saw in those previous pictures. And that might make it harder to detect, and it might allow for more focal impairment of blood flow as it transits through the heart without the presence of a large pericardial effusion. So these are some pictures from one of the echoes done in our lab. On the left, it shows a subcostal view where we can see a fairly large pericardial hematoma abutting the right ventricle, which is suggestive of possible impairment of RV flow. But on the right, which is an apical four-chamber view of the same patient, we actually see that the right ventricle looks to be filling quite well. And I don't believe that there was actually any hemodynamic compromise in this patient. Okay, so this is our next case. I don't know if any of the cardiology residents want to take a stab at it. And if not, I will talk in 10 seconds. Okay, I'll just go over it. So this one came into the lab earlier this week, actually.
I can do it. I can do it.
Sure.
So we're looking at a view of the aortic arch, and we see the branches coming off of it, and we see something in the left subclavian there that looks like it could be a dissection plane.
Yeah, good. So exactly, it's a suprasternal notch view. We can see the aortic arch nicely going to the descending aorta, and we can see the branch into the left common carotid artery and the left subclavian artery. And both look like they have this linear intimal flap. It's not so well seen here, but the flap also extends into the descending aorta. And so I'll come back to that image in a little while. So when we're looking at the aorta, there's multiple types of acute aortic injury with distinct radiographic and sonographic appearances. An aortic dissection is the most well-known and commonly described type of acute aortic syndrome, which is caused when there's an intimal tear with dissection between the intima and the media that creates an intimal flap with a false lumen and a true lumen. The second type of acute aortic syndrome is called intramural hematoma, which is caused by the accumulation of blood within the wall of the aorta without an intimal flap. So this is thought to be due to injury and rupture of the vasovasorum, which are small capillary-like blood vessels that supply blood to the media and the adventitia of the aorta and other large caliber blood vessels. And then the third type of acute aortic syndrome is called a penetrating aortic ulcer, which is essentially when you have pre-existing atherosclerotic plaque that ulcerates, and this ulcer burrows deep enough down that it enters the subintimal layers, and you get blood from the lumen of the artery going into the wall of the artery and forming this hematoma. The acute aortic syndromes are further classified by the Stanford and DeBakey criteria, or classifications. We usually refer to the Stanford classifications in type A or B dissections. A type A dissection affects the ascending aorta up to the left subclavian artery, and it may or may not include the descending aorta, whereas a type B dissection only affects the descending aorta. The DeBakey system further classifies this into whether or not a Stanford class A dissection affects or does not affect the descending aorta, and it further defines the extent along the descending aorta that is affected and whether or not it goes above or below the diaphragm. So in blunt traumatic injuries or deceleration injuries, the aortic injury tends to happen around the area of the aortic isthmus, which is where the ligamentum arteriosum fixes the more proximal aorta in place. The ligamentum arteriosum is the remnant of what was the fetal ductus arteriosus. And because it creates this point of fixation and the distal aorta is relatively mobile, this transition point is susceptible to increased shear stress during trauma. Aortic dissections and acute aortic syndromes are imminently life-threatening, and many people who unfortunately have this happen will die at the scene or before they reach the hospital. And so in those who do reach hospital, rapid identification and treatment is crucial. The mortality data is highly variable depending on the center and depending on the circumstances under which the acute aortic syndrome was diagnosed. And it really depends on time from symptom onset until they receive treatment and the type of treatment that's received, whether it be medical treatment, surgical treatment, or a TVAR or an endovascular procedure to fix the dissection. Medical management generally renders the poorest diagnosis and is likely only done in patients who aren't considered candidates for a surgical procedure or an endovascular procedure. And although it's not specifically stated here, one would imagine that the mortality rates are even higher for people who present with trauma-related dissection due to the severity of their injury and other co-injuries, whereas the mortality data here is sort of all comers who come to hospital with an acute aortic syndrome. There are multiple different imaging modalities available, such as transthoracic echo, transesophageal echo, CT, MRI, and each has their role. Transesophageal echo has very high sensitivity and specificity for the diagnosis of acute aortic syndromes, and TTE is pretty good, but not nearly as good as transesophageal echo in this purpose. CT scans are also excellent, but it can be quite challenging to facilitate in an unstable trauma patient. And when we look at all acute aortic syndromes, the sensitivity of TTE is about 73 to 100%, depending on the study, with specificity ranging from 71 to 91%. And for transesophageal echo, sensitivity ranges from 86 to 100% with a specificity of 90 to 100%, which is quite good considering these are tests that can be done while the trauma patient is in the emergency department or in an ICU and not requiring transfer to a CT scan. So transesophageal echoes are clearly good based on this data because they're extremely sensitive and specific for traumatic aortic injury. They're portable, you can use them rapidly, and you can use them intraoperatively for endovascular repairs or to assess the quality of surgical repair. It also has a shorter scanning time than the CT scan and can be done in any monitored setting in the hospital. And it also provides a better assessment of the aortic valve than a CT scan can provide. So there's a few key features to look for dissection on echo. We look for an intimal flap with the development of a false and a true lumen. We can look for blood flow in the true versus the false lumen, and we would expect to see that the true lumen has higher flows and an increased diameter in systole, as one would expect of any artery. Whereas the false lumen, we see poor flow, and we see that its size generally decreases in systole, and we get increased flow and increased size of the false lumen and diastole. And then we can also look for the company that the dissection keeps. So we can look for pericardial effusions because of possible dissection into the pericardial space and the development of hemopericardium. That can lead to tamponade. We can look for wall motion abnormalities, especially in the right coronary artery territory, as well as suggestive ECG changes that could occur because of a right coronary artery dissection. We look for aortic insufficiency because of possible dissection into the aortic annulus, causing disruption of its structure and malcoaptation of the aortic valve cusps. And we can look for a hemothorax, which may suggest pseudoaneurysm or rupture of the aorta, which would also be accompanied by very severe hemodynamic instability. And then we can look for other clinical or biochemical signs of end organ dysfunction, such as neurologic symptoms, renal dysfunction, back pain, bowel ischemia. So this is a different patient than I showed before. This is a parasternal long axis on the left with a parasternal short axis on the right, and it shows color flow going from the sinus of Valsalva into the right ventricular outflow tract. And this is diagnostic of a rupture of the sinus of Valsalva into the RV. We can see that the flow is highest in diastole when the aortic valve is closed and when there's no forward flow, when you would sort of expect the blood to be filling into the coronaries as well. This is the same patient as I showed previously. So on the left is the picture without color, and on the right you can see the suprasternal notch view with color Doppler placed over the dissection flap, and you can see how the color very nicely goes through the true lumen, and you can see how that cavity how that lumen increases in size during systole, but the false lumen shrinks in size during systole and expands during diastole. This is a view of the descending aorta from the subxiphoid area. In the first view on the left, without color, it's a little bit difficult to discern the presence of an intimal flap, but when the color is turned on, you can see that very clearly there's pulsatile flow only in one part of the aorta and absent in that more posterior portion. And again, you can see the expansion of the true lumen with systole and the expansion of the false lumen in diastole. When we put a pulse wave Doppler through the true lumen and the false lumen, you can see on the bottom left picture, this is with a pulse wave Doppler and the true lumen, where you get good pulsatile flow seen in systole after each QRS complex. But then when you move the pulse wave Doppler over to the false lumen, you see that the velocity become very blunted and have quite poor flow, as you would expect. So myocardial contusion is another common concern in patients who have sustained injury to the chest wall. Myocardial contusion or bruising is caused by rapid deceleration injuries that result in either direct increased pressure on the myocardium or indirect shearing forces from increased thoracic pressure that can affect the myocardium. Myocardial contusion usually affects the anterior structures, namely the right ventricle and the right atrium. And they're also more commonly affected because they're situated right behind the sternum. Myocardial contusions have quite a high mortality, although it's difficult to say exactly what the number is because it's also a very difficult diagnosis to make. But in a study of patients who had immediate death after blunt chest trauma, post-mortem exam revealed that about 14% of those people had evidence of myocardial contusion. So as mentioned, it's a fairly difficult diagnosis to make because there's no single specific test other than direct pathologic examination. The cardiac biomarkers such as CK and CKMB are not specific, and they don't detect the presence of contusion or the likelihood of complications. Troponin, while highly sensitive and specific for cardiac injury, is very non-specific as to its precise cause. And as we know, there are often other systemic factors that contribute to an elevated troponin during acute trauma. The ECG is also of limited use. Some animal studies have shown that there's associations with ST and T wave abnormalities and conduction disease and ventricular arrhythmias with myocardial contusion. But the ECG is also intrinsically sort of insensitive for this problem because the 12-lead surface ECG primarily shows electrical activity in the atria and the left ventricle, with right ventricular changes mostly being overwhelmed by the relatively large left ventricular mass. There's also many other common metabolic derangements in patients with trauma that can affect the ECG. At the molecular level, we see certain changes, or not molecular, but at the pathological level, we see irregular myocyte necrosis, epicardial hemorrhage, and this can ultimately extend inwards and become an actual transmural injury. We may see the development of right ventricular dysfunction, and this can precipitate cardiogenic shock through decreased left ventricular preload or decreased left ventricular compliance from a septal shift from the right to the left. The RV dysfunction can occur quite early on in the presentation of a trauma, and it can last for weeks afterwards. We can also see electrical instability that usually occurs within the first 24 to 48 hours, and these patients may have other associated valvular, coronary, or aortic injuries. So this is a pathologic sample post-mortem, obviously, where the left picture shows a transverse section that looks sort of similar to our parasternal short axis view on echo. And you can see that there is necrotic blackened tissue extending from essentially the anteroseptal region laterally all the way to the inferolateral wall. And on the right is a light micrograph with hematoxylin and eosin staining showing disruption and disarray of the cardiomyocytes and infiltration of red blood cells into the tissue, which is diagnostic of a myocardial contusion. So there's some echo findings that we look for, such as wall motion abnormalities, although they can be difficult to see in the RV, and the left ventricle is less commonly affected. We can see right ventricular dilatation or dysfunction and right ventricular failure. Transthoracic echo is often challenging in these patients as they often have severe anterior chest wall injury or deformity. And they may also have concurrent pulmonary injuries such as pneumothoraces, hemothorax, or pulmonary contusions that can obscure our field of view. Furthermore, the findings such as regional wall motion abnormalities or right ventricular dysfunction are fairly non-specific and may have many traumatic and non-traumatic causes. Transesophageal echo can also be used. It gives more reliable images than transthoracic echo in this case. And in studies of transesophageal echo for myocardial contusion, they found that about 42% of people with suspected contusion were found to have ventricular dysfunction. So less than half. And in those with ventricular dysfunction, it was primarily right ventricular dysfunction, with about 60% of people having right ventricular dysfunction. This was not associated with ECG changes or CKMB levels or with injury severity scoring systems, again, just showing that these are not particularly useful tools to diagnose myocardial contusion. Okay, so one more, if anybody wants to volunteer for this one. If not, I will go. Okay, I'll go over this one. So on the left, we have a parasternal long axis view showing a somewhat small left ventricular cavity. We can see an enlarged right ventricle at the top of the image. And on the right picture, looking at the parasternal short axis, we can see that the right ventricle is grossly enlarged. And there is septal bowing towards the LV, forming this classic D-shaped septum, suggestive of volume and pressure overload. The patient is also quite tachycardic here. And then moving on to the apical forechamber, you can now see a small pericardial effusion located near the RV apex. You can see again that the RV is grossly enlarged and nearly the same diameter as the LV. The septal bowing is still visible. And if you really look at the right ventricular free wall myocardium, you can see that it is somewhat hypokinetic with impaired thickening, but the RV apex still continues to be quite mobile and contracts better than the rest of the RV, which is known as the McConnell sign. So in addition to direct traumatic injury to the myocardium, as with cardiac contusions, acute right ventricular failure can also occur because of sudden and dramatic increases in pulmonary arterial pressure. During the initial phase of the trauma, the major considerations for this diagnosis are fat embolism, fractured long bones, and air embolism, either through air that's entrained from outside through an open wound or through iatrogenic causes such as line placement or neurosurgery. In the days after the initial resuscitation, when patients are very high risk for pulmonary embolism because of impaired mobility and coagulopathy, we should be thinking about pulmonary embolism as a potential cause for RV dysfunction, and air embolism can also occur from iatrogenesis in this phase. So the McConnell sign is defined as akinesia of the RV mid-free wall with normal RV apical motion, and it's classically been described in acute pulmonary embolism. There's a few proposed mechanisms for why this happens. It's thought that the normal and often hyperdynamic left ventricle may pull at the RV apex, making it appear to be functioning well. It's also thought that to accommodate the increased right-sided pressures, the RV assumes a more spherical shape in order to improve its overall mechanics. And then it's also thought that there may be some supply-demand mismatch occurring on the right ventricle in the context of suddenly increased RV afterload. And this causes some RV ischemia due to increased wall stress and reduced coronary perfusion because of high right ventricular end diastolic volume and end diastolic pressures and decreased blood pressure. And so I'll just go over this in the interest of time. So on the left side of this picture, we can see parasternal short axis view at the papillary muscle level. showing essentially hypokinesis in all of the wall segments. But then as we move down to the bottom left picture, which is taken in the short axis at the level of the apex, we actually see that the apex is contracting quite well. And then on the right side, we can see a apical four-chamber view, again showing that the left ventricle seems to be quite hypokinetic or akinetic at the base and into the mid portion, but the distal third of the ventricle still seems to be contracting normally or probably in a hyperdynamic fashion. And so this echo was taken in a young woman who had sustained an intracranial hemorrhage. And the diagnosis was made of stress-induced cardiomyopathy. Now, stress-induced cardiomyopathy is classically described as this Takotsubo syndrome, which characteristically has apical akinesis or dyskinesis, whereas here we see the opposite finding with a normal or hyperdynamic apex and a dysfunctional proximal portion of the left ventricle, which is also known as reverse Takotsubo. So when we're doing cardiac assessment of a trauma patient, obviously left ventricular systolic function is an important aspect of our examination. So we can look at gross LV function overall as in order to guide overall volume management and determine if the patient is profoundly volume deplete, or if they have left ventricular dysfunction that can necessitate a more cautious approach to volume resuscitation. And we may detect major wall motion abnormalities on our initial assessment. So the wall motion abnormalities could be pre-existing, or they could be from coronary ischemia related to many different mechanisms in the context of the trauma. So commonly we'll get type 2 myocardial infarctions from supply-demand mismatch because of high myocardial oxygen demands during acute stress, low oxygen delivery due to blood loss, or dysfunction from acidosis, mitochondrial dysfunction. We can also get the development of type 1 MIs from acute plaque rupture or thromboembolism during this state of sympathetic overdrive, and since trauma also induces a lot of coagulopathy. And we can also get coronary artery dissection from a type A dissection into the right coronary artery. And then we could also see wall motion abnormalities because of stress-induced cardiomyopathy, as we saw in the previous picture. And it's important to recognize this because knowing whether or not there's a potentially vulnerable myocardium can help to plan the resuscitation and improve the overall chances of survival. And then finally, if we think about the valves, they can be affected by trauma and can significantly impair hemodynamics, especially if they affect the mitral or aortic valves, in which case they can be acutely destabilizing. So recognition of new valvular issues in the context of a trauma is extremely important to help optimize the resuscitative strategy. And then you can get valvular issues because of direct leaflet injury to either the aortic or the mitral valve, as well as through disruption of the mitral annulus, rupture of the chordae tendineae, papillary muscle rupture, either through direct injury or from ischemia. And similarly for aortic insufficiency, you can get it because of direct injury to the valve or because of dissection into the aortic root. So just briefly, a few words on echo-guided resuscitation. Echo can be very useful in the acute resuscitation of the trauma patient, and these principles can also be extended to ICU level care or CICU level care and perioperative care. I think there's two main purposes when we use echo in acute resuscitation. Number one, for defining what the etiology of the shock is, and number two, for using it to help us optimize hemodynamics. So there's multiple protocols that have been suggested for echo and ultrasonography in the context of undifferentiated shock and in trauma. There's the FAST exam, which we probably all have heard of before, where you look at the hepatorenal, splenorenal, subxiphoid, and bladder spaces to look for evidence of free fluid or blood. This is a newer, but not that new model that I've heard of from a few people, called the RUSH exam. It's a bit more comprehensive than the FAST exam and includes the three main cardiac views at the peristernal long axis, apical four-chamber, and subxiphoid areas, as well as the areas that are seen on the FAST exam, the hepatorenal, splenorenal, and bladder spaces. And then it includes a sliding view along the abdominal aorta and two pulmonary views. And in doing so, can identify almost any of the major causes of shock. and with some practice can be done within a few minutes to take a quick look for any evidence of blood or pneumothorax or other free fluid. In terms of hemodynamic optimization, probably the most common thing that we think about is IVC size and collapsibility, which I'll just put on the parameters for, and how they are used to estimate right atrial pressures. In the context of trauma, it can be challenging to use this measurement because it's a lot less useful when somebody is intubated, as many of these patients are. Other methods for using echo for hemodynamic optimization have been proposed, such as the IVC distensibility index, where you look for greater than 15% respirophasic change in the diameter of the IVC of a hypotensive patient. And this has been proposed for patients who are mechanically ventilated and is used to predict whether or not they'll be fluid responsive. It had reasonable sensitivity and specificity in the one study that I looked at, but of course the studies that have looked at this have all been fairly small and hasn't been extremely rigorously studied or validated in all populations. Passive leg raise is something I've also seen used from time to time, where with passive leg raise, you look for an improvement in the stroke volume of greater than 10% within 60 seconds. And this is also used to assess whether or not somebody may be responsive to volume. This can be used in patients who are ventilated or spontaneously breathing. And you could either assess whether or not it's worked by looking at stroke volume through the LVOT or by looking at response to blood pressure. And sorry, just looking at the time. So finally, just to kind of summarize, this is the framework that I would use when I'm going to assess a patient who has had trauma and I'm going to do an echocardiographic assessment. So I would try to think about their volume status. I would look at their left ventricle and right ventricular function and wall motion, look at their valves, look for pericardial effusion, and try to assess their ascending aorta, the arch from the suprasternal area, and the descending aorta from the subxiphoid area. And then finally, I would look for other causes of shock that might be contributing, such as a hemothorax, pneumothorax, or free fluid in the abdomen. I think there's going to be an increasing role of echo in trauma and in resuscitation in general. Recent ASC statements have come out recommending for additional trials to be done to understand the role of transthoracic and transesophageal echo in multiple acute medical and surgical conditions. And I think there's also increasing demand from physicians to learn about echo from multiple specialties such as emergency medicine, trauma surgery, anesthesiology, GIM. I think there's a lot of applications of echo, and we in cardiology will also play an important role in educating other people about how to use echo and how to interpret the findings. So these are my references, and thank you all for your attention. Happy to try and answer any questions that you may have.
So thank you, Samir, for this very comprehensive review, and it's a very good sort of review on a number of different conditions that we have, and also the future use or the current popular use of POCUS and in emergency and trauma management. So just a quick historical tidbit: the McConnell sign was actually developed around 1997, 1998, published in JACE, and was actually by a cardiology or echo fellow that was at Brigham and Women's with Dr. Pat Combe. So that was how it was started, and we've been quoting it for the last 20 plus years. So with that in mind, I really appreciate you reviewing about the future of the POCUS and use of trauma. How do you see like cardiologists playing in this field as more and more people are learning to use ultrasound as the extension of our physical exam?
Yeah, I think that we're probably not going to be the people who are called down to the trauma bay the majority of the time. But I think because so many other specialists are interested in learning about it and are already using echo for a variety of applications, it becomes incumbent on us to do our best to educate people on what the common findings are that we're looking for and how to interpret them, how to tell artifact apart from real findings, and what is concerning and should prompt further assessment either by cardiology or by cardiac surgery. So I think from an echo perspective, we get lots of people from cardiac surgery, from emergency medicine who come in to train with us and to learn to do echo. So I think if we could even focus on findings that might be relevant to their specialty, I think we can be very helpful to their practice.
Yeah, right on. I think in the past, there was a bit of resistance of, everybody has their own turf, and there was some resistance in terms of, other people getting into the echocardiography or using POCUS, but I think, that thinking has changed, especially in the last 7 to 10 years, where, we should all work together as one big family to try to help our patients. And, we can also learn from them as well in terms of doing ultrasound in other organ system. When we do our echo, we can see other things, and incorporating lung ultrasound, for example, as part of the assessment of the fluids in the lung, et cetera, et cetera. So I think, we just keep expanding on our horizon as we move. So any other questions and comments from our colleagues in the next 6 minutes?
I have a quick question. It might be more geared towards the echo team rather than Samir. But if there's a concern for an aortic dissection in a hemodynamically unstable patient, and it's not 100% confirmed on transthoracic echo, but they're too unstable to go to CT, in terms of logistics of getting a TEE, I'm just curious because I know usually it's done intraoperatively, but if the diagnosis is still not 100% confirmed yet, I'm just curious to know if what the next step would be. Would it just be to do a TEE in emerge, or what would the suggestion be?
Maybe I'll take this question.
Yeah, sure.
Yeah. So basically, we have a TEE service 24/7, and we are geared towards doing transesophageal echo actually portably anywhere in the hospital. And so, if it's needed, some patients unstable, or someone who has really bad renal failure, who couldn't go to CT scan, we are here to actually do the transesophageal echo, and at any time, any day. Obviously off hours will take a bit of time for us to come in, because for obvious reasons, but otherwise during work hours, we're right here and there for you. But I'll let my other colleagues answer as well.
Yeah, thanks, Chiming. Just want to remind folks that, before the plethora of cardiac CT, the availability, CT scans and emerge, TEE was actually probably the first choice for imaging for patients who were thought to have an acute aortic dissection. But obviously things have changed over the years, and CT is certainly is more 24/7. Whereas transesophageal echo in the middle of the night, you have to call the cardiologist, the echo fellow, so there's a bit more delay. So, but yes, we're available for the hemodynamically unstable patients, plus the patients who have significant renal insufficiency that they don't want to do a contrast CT. Samir, I did have an additional question. You did talk about the use of POCUS in the trauma patient. But because of issues that you also discussed with regards to training, smaller handheld systems, did you come across any studies that looked at the accuracy of POCUS versus standard full transthoracic echo in terms of some of these abnormalities that you've talked about that might be seen in a trauma patient? I guess the big question is, do you have a sense as to how much is potentially missed or could be missed with POCUS versus a full study?
Yeah, it's an interesting question. I didn't see anything specifically looking at that or seeing if there were kind of big discrepancies between the findings on the bedside POCUS in the trauma bay versus the more comprehensive echo done subsequently. But I imagine that there probably are things that are missed or misinterpreted. As to whether or not that's because of just poor image quality, lower quality transducers that are available, or lower quality probes that are available in the trauma bay versus when our sonographers come by to do the examination, or because of people interpreting the images that are less familiar with echo. probably a combination of all those factors. So I think hopefully as the quality of portable transducers improves and as understanding of different echo findings from different providers improves, that gap in the quality of the finding or understanding of the findings, if it is present, will hopefully narrow. But yeah, I haven't seen anything specifically on whether or not there are differences.
Yeah, I agree. It's a moving landscape. The handheld systems are definitely improving, and the expertise from non-cardiology aspects are also getting better. We've seen a number of correlative studies for focus for other things like assessment of LV systolic function, for example, picking up different valvular abnormalities. So I suspect you might see some, in the future, might see some more correlative studies in the trauma population.
For sure.
Thanks.
Thank you.
Yeah, just want to quickly add to that. Our Kingston group actually did some very interesting study on this, and they did almost like a genius corner for the POCUS colleagues from emergency as well as from the ICU. So people have acquired images will be stored in a mini PAC system, and then like the echo people in the echo lab would provide consultation on them. So it begs to have a mini PAC system for our colleagues who does POCUS, so we can actually access them or review them for them. So that's actually one of the areas we could consider offering at our institution and others as well. So some interesting project that we can do with our emerge colleagues who may be on the line today. Then we can have conversations about that. So like we favor open communications and working together rather than being siloed, if anything. Thank you.
Yeah, Chiming, just to add to that, actually, I can tell you that there's been discussions at a high level, mostly driven by Alberto Goffi with regards to centralization and storage of images and review, as you've mentioned.
Yep, definitely. Yep, moving target area. Excellent. Well, thank you. Now it's 9:01, so thank you for this really interesting topic and review, and have a wonderful week.